PSE webinar, Managing Thyroid Conditions in the Time of COVID-19. To start, we will have the PCS hymn and the welcome remarks from PCS President Dr. Jose Antonio Salud. Let us pause for a moment of silence in prayer for our fallen colleagues and a past president of the Philippine Academy for Head and Neck Surgery, Dr. Melanio Cruz, who recently passed away. Okay. For the next part of the program, let us hear from Dr. Jose Antonio Salud, the PCS president, his welcome remarks.
Okay, good morning, everyone. I hope you're all wide awake, and I hope you don't, because you see me every day, I hope you don't get tired of seeing me. I'm practically present in all webinars this past few days. But as we prepare for the eventual lifting of the modified ECQ around the country, maybe it's best that we are prepared also as far as practitioners of surgery and medicine and the management of head and neck conditions, particularly the thyroid. all of us should be prepared in the next few weeks. I believe in all the for among surgeons, the most difficult, the ones affected most are the ones who manage the head and neck condition, particularly head and neck surgeons from PAHNSI and PSGS, ENTs, and even the anesthesiologists. They have difficulty now managing cases involving head and neck because of the potential risk of getting infected. But this is an opportune time for this webinar so that we can understand better and be prepared for the next few weeks as we start our practice and move on. Because I hope with this webinar, we are able to understand best how to manage this condition, the diagnosis and management of thyroid conditions. I'd like to thank once again TNP, Jeff Domino, and the Telemedicine Network of the Philippines, the PSUS, the PAHNSI, the Philippine Thyroid Association, and of course the Philippine Society of General Surgeons, who is celebrating their 21st anniversary today, right now. And congratulations to the PSGS and to all the other societies who have continuously been producing and coming out with very informative webinars. Now, I'd like to remind everyone also that next week we will be having our 46th Philippine College of Surgeons Mid-Year Convention online on May 28 and 29. Doquity will release the registration link very soon, so you can start registering. This is free, for free. People have been asking if there is a registration fee, but this is for free. So thank you for inviting me to give the opening remarks. I know we have to make people understand, not just the patients, but the general surgeons, the ENTs, the thyroid doctors, and all those who manage thyroid conditions. We have to understand how best to proceed. So that hindi lang salita, pero hopefully soon may magagawa na rin tayo. So once again, thank you very much. Congratulations to PSGS, and thank you for all those who organized this webinar this morning. Salamat po.
Thank you, Dr. Salud. On behalf of the different organizations who collaborated in making this webinar possible, the Philippine Society of General Surgeons, Philippine Society of Ultrasound in Surgery, Philippine Thyroid Association, and the Philippine Academy for Head and Neck Surgery, we are grateful to PCS and the CSE Committee and to Telemed for supporting this webinar. Yes, we are in a pandemic, and it's a natural thing for us to always find ways to adjust and survive. As physicians, we have a responsibility to our patients in spite of the risk that we face. So after 2 months of the extended or the ECQ, some of the areas in the country are now in GCQ. And for the healthcare system, this means resumption of some of its usual activities, including clinics and elective surgeries. Now, with regards to managing thyroid conditions, we hope to learn from our speakers today on how to best manage them, considering the presence of COVID-19. So I would like to present the excellent lineup of speakers for today. Jeff, can we have the slides? Okay, so first is Dr. Alfred Philip de Jos. He is also the co-director for this webinar and the chair of the committee on PCS-CSE, graduate of UP College of Medicine, had his general surgery and fellowship training in the same institution, currently the training officer in Jose Reyes Memorial Medical Center, treasurer of PCS Metro Manila, president of PSUS, and an associate professor of the St. Luke's College of Medicine. The next speaker is Dr. Roberto Sarmiento, a general surgeon, head and neck surgery, finished his Doctor of Medicine at FEU Memorial Foundation, had his residency in general surgery at Jose Reyes Memorial Medical Center, fellowship in UP-PGH, currently a medical director of Mother Seton Hospital and the vice president of the Philippine Society of General Surgeons and Director in charge of the PSGS Head and Neck Study Group. We also have from our colleague, otorhinolaryngology, head and neck surgery, head and neck oncologic reconstructive microsurgery, Dr. Adrian Fernando, a graduate of UE College of Medicine, had his residency training in otorhinolaryngology, head and neck surgery in the same institution, a full fellowship training in head and neck microvascular reconstructive surgery in the fellowship consortium of several hospitals. Board of Trustee of the Philippine Society of Otorhinolaryngology, Head and Neck Surgery, a member, instructor of the Japan Team Oncology Program, Assistant Professor of UERM College of Medicine, Dr. Adrian Fernando. We are very fortunate to have as guest speakers, non-surgeons, our partners in managing thyroid conditions. From nuclear medicine, we have Dr. Wenceslao Lauderes, graduate of West Visayas State University College of Medicine, had his master's in health governance from in Ateneo, finished internal medicine, St. Joseph, Negros Occidental, and nuclear medicine fellowship in Jose Reyes. He is currently the Chief of Medical Professional Staff in Jose Reyes Memorial Medical Center and a faculty of UST Medicine and Surgery. He is the immediate past president of the Philippine Thyroid Association. Okay, next is Dr. Nemencio Almare Nicodemus Jr. He is a practicing endocrinologist, a graduate of UP College of Medicine, had his residency and fellowship in the same institution, a visiting clinical program, Mayo Clinic, Rochester, Minnesota, past president of the Philippine Society of Endocrinology, Diabetes, Metabolism, regent of the Philippine College of Physicians, president of the Philippine Thyroid Association, a professor at UP College of Medicine, Department of Biochem, Molecular Bio, and training officer of UP-PGH, Department of Medicine. And last but not the least, for the speakers, we have Dr. Jeremy Jones Robles, also an endocrinologist, a graduate of the Cebu Institute of Medicine, had his residency training at the Cebu Veles General Hospital, fellowship, adult endocrinology in UST, president of the Philippine Society of Endocrinology, Diabetes, Metabolism, treasurer of the Philippine Thyroid Association, a consultant for the section of endocrinology, diabetes, metabolism, Chongwa, Cebu City, training officer of the Department of Internal Medicine, Cebu Veles General Hospital, and an associate professor of the Cebu Institute of Medicine. And to be the host or co-host, our very reliable, very popular Dr. Jeffrey Domino. He is a graduate of medicine from the University of Santo Tomas, had his residency training in general surgery, St. Luke's Medical Center, board member of PALES, and head of the section of MIS, Advanced Laparoscopic Robotic Surgery, Institute of Surgery, St. Luke's, as well as section chief of endocrine surgery in the same institution. And we all know that he is the president of Telemedicine Network of the Philippines. Okay, so I know everybody's now waiting, so let's hear it from our speakers. Okay, for the first talk, let's welcome Dr. Alfred Philip De Jos, who will discuss thyroid nodule evaluation using neck ultrasound to select patients needing immediate care.
Okay, good morning, everybody. Okay, so I'm here to discuss what many consider as an essential tool in the complete assessment of thyroid glands, which is your thyroid ultrasound. So I have no disclosures, and for this talk, we'll just concentrate on the following. First, we will be discussing the indications for use of ultrasound in the assessment of thyroid nodules, and I will be enumerating what features we use to classify a malignant nodule, and a very, very short discussion on ultrasound scoring systems developed by different specialty societies, and what we can do right now, okay, the limitations that we have during this pandemic. Okay, now the incidence of thyroid nodules is very, very low. Okay? As you can see here, it is present in only 5% of women, much lower in men, at around 1%. But as the age of as the population ages, okay, the incidence increases to around half of that population. Okay, it increases to around 50%. Now these numbers, okay, are incidence based on palpation. When we use an ultrasound, as you can see here, okay, the incidence significantly increases. It increases to around 50 to 70% of the population. And most of these are what we term or what we call as incidentaloma. Okay? These are thyroid abnormalities seen, okay, in patients who underwent imaging for other causes. Now, of the 50 to 70% detected, only around 7 to 15% will be malignant. So as you can see, an ultrasound evaluation surpasses PE for detection of thyroid nodules. Overall sensitivity is pegged at around 83.3%, but as you can see, there is a wide range with regards to sensitivity and specificity, mostly because, okay, as we know, ultrasound is very operator dependent. Okay? Now, aside from the detection, these are the advantages when we use ultrasound in fully assessing thyroid nodules. It's considered to be the most cost-effective imaging modality around. Okay? It's non-invasive, it's readily available. Okay? Compared to the other imaging modalities, it's cheaper. Okay? And for the patient, it would be safer because the patient's not exposed to any ionizing radiation. Okay? And uh, the real-time nature of ultrasound allows us for accurate image-guided biopsies or aspirations. So it aids us in interventional procedures. Okay? We can also use it to assess the extent of the disease if it turns out, if the nodule turns out to be malignant, because we're able to evaluate the nodal basin, and we can also assess invasion with the use of an ultrasound. Okay? Now, it also identifies small nodules that cannot be palpated in the physical examination. Nodules as small as 3 millimeters can be detected by an ultrasound. And there's no need for any special preparation. You can just perform it right away. Okay. The major limitation of ultrasound in thyroid imaging is that it cannot determine thyroid function. So it's mainly anatomical. Okay. So right now, we use ultrasound in the detection and characterization of thyroid cancer, okay, uh, to check for the extent, detection of nodal metastasis in the nodal basin. Okay. It aids us in our biopsy techniques. And for patients who underwent surgery or underwent treatment already, we use it for follow-up and surveillance. Okay. Now, there are 5 major characteristics or features that sonologists use, okay, to determine whether a nodule could be malignant or not. Okay. The first one would be echogenicity, and this refers to the brightness relative to normal thyroid parenchyma. Okay. So a normal parenchyma would appear homogeneously hyperechoic or relatively bright on sonography. Now, this bright appearance reflects the relatively high number of acoustic interfaces. And this is brought about by microfollicles present within the normal thyroid tissues. Now, malignant nodules are described as having a hypoechoic appearance. Okay? So it's darker as compared to the normal thyroid parenchyma. Uh, This is because there is increased cellularity and cellular compaction and paucity of microfollicles present in malignant nodules. Now, because of that, there's less acoustic interfaces. Okay, that's why these nodules appear darker. Okay. Second criteria would be based on measurements. So, malignant nodules are usually characterized as taller than wide. It's also called the AP to transverse ratio. Of all the parameters or characteristics used to describe malignant nodules, this is the most objective measurement parameter because it involves accurate measurements. Okay. Now, this occurs in malignant nodules because the centrifugal tendency in tumor growth does not necessarily occur at a uniform rate in all dimensions. Third would be your microcalcifications. These are most commonly found in papillary and medullary thyroid cancers and are described as punctate hyperechoic foci. Okay. The size usually is less than 2 millimeters. So of all the features, these are the ones that are most closely associated with malignancy. In papillary thyroid cancer, they represent areas in the thyroid where samoma bodies are found. Okay. Now, aside from microcalcifications, you may also find macrocalcifications there. These are lesser in terms of sensitivity for the diagnosis of malignant thyroid nodules because they can be seen in both benign and malignant nodules. So they are described as larger than 2 millimeters with posterior acoustic shadowing, as seen on the picture on the upper right. Okay. So this represents areas of fibrosis, degeneration, and necrosis. Okay. Sometimes we also see peripheral rim calcification. Okay. Now, histologic correlation is still not that clear as of this moment. They may represent compacted thyroid tissue, okay, or an enhanced capsule. Okay. The fourth one would be your margins. So malignant nodules are characterized as having microlobulated, spiculated, or infiltrative margins. So this corresponds to invasion into the surrounding thyroid parenchyma. In the picture here, what you could see would be your what we term our microlobulated margins. Okay? Of all the parameters used, this has the highest inter-observer variability. So it's not that reliable. Okay, and then lastly, we have vascularity. So for this one, you need to use the Doppler function of your ultrasound. Okay, so malignant nodules are characterized as having marked intrinsic hypervascularity. So meaning there's more flow in the central portion as compared to the peripheral area, which is more characteristic of benign nodules. Okay, so in one meta-analysis, they identified these three as the most useful in determining whether a nodule is malignant or not. Okay, you have the taller than wide shape, presence of microcalcifications, and having spiculated microlobulated margins, even though it is very subjective. But we have to remember that there's no single sonographic feature that can be used to differentiate a benign from a malignant nodule. You've seen the numbers that I've presented together with in the previous slides, the sensitivity, specificity. You see that they are not that high. Okay, so no sonographic feature is highly sensitive and specific. Okay, so we should always consider the overall appearance and collective features, and we should always correlate it to our clinical findings. Okay. Now, the exams done usually include examination of the other areas of the neck. Okay. As I mentioned before, this is a very subjective method. It will depend on the experience of the one performing the imaging test. Okay. This is why there is substantial inter-observer variation in the reports that we receive. Okay. Now, we need to standardize this. Okay. We need to standardize how we report it. We need to standardize how we describe these features, okay, in order for us to reduce inter-observer variability. A structured reporting template would lead to better description and assessment of malignant nodules. Right now, okay, several subspecialty societies have already done this. We have multiple criteria in existing right now, okay, to help us, okay, in assessing ultrasound features of a malignant thyroid nodule. Now, these scoring systems allow us easier comparison of examinations. There are two types at present. Okay, you have the pattern-based, which are the ones used by the ATA, the British Thyroid Association, and the AACE. And then you have the point system developed by the American College of Radiology, what they call the TIRADS, or the Thyroid Imaging Reporting and Data System, just like the BIRADS for the breast. Okay, now, studies have shown that pattern-based scoring systems have high sensitivity and negative predictive values, while point systems have high specificity, positive predictive value, and accuracy. Okay, but as you can see, there's several there. You even have modifications of the ACR TIRADS. You have one in Korea and several others. Okay, we lack a single generally accepted set of guidelines or scoring system that we can use. Okay, so this is just a summary of the scoring systems in existence. Okay, as you can see, they're categorized into several classifications, and you have there the risk of malignancy per classification. Okay, now there also exists advanced techniques that some already employ to diagnose or to differentiate a benign from a malignant nodule. One of them is elastography. Now, this technique estimates the stiffness of the tissues. Okay, so the examiner measures the degree of distortion while applying pressure, okay, through the transducer. Malignant nodules are described as being harder and deforms less. Okay, but this one is not yet that accepted among the different guidelines, except in I think in AACE they already included that. Okay. Another would be your contrast enhanced ultrasound. Oh, this evaluates the microvascularization present inside the nodule. Okay, so they use different enhancement patterns as diagnostic criteria. The problem here is that there are two ways of classifying them, okay? The two systems, so there's no unified way. One would describe nodules as homogeneous, heterogeneous, non-enhancing, or no enhancement. Another would describe nodules as having circular enhancement, high, equal, or low enhancement. Okay? But generally, okay, nodules that have low enhancement or heterogeneous enhancement are deemed malignant. Okay? So, although these two techniques appear promising, promising, okay, they need to be standardized. Okay, so at present, they seem to be expensive, yeah, time-consuming, and are of limited utility in selecting patients for surgery. So we can still utilize it as supplementary methods to your basic ultrasound examination. Okay, so what do we do right now in this year of the pandemic? So before we go there, let me just review some facts. Okay, we know that thyroid malignancy is rare.
Hello, Doc Jep. Na-disconnect po yata.
Hello? Hello?
Yeah, go ahead, AP.
Hello? Can you hear
Yeah.
me?
Yes,
Yeah,
AP.
okay.
Yeah.
Okay. It's just, I'm going to my last slides.
Yeah. Pa-share slide
Show
na lang ulit.
yourself daw kasi.
Okay. Okay.
Oo. Yan. Pa-on daw yung video mo, AP. They're
There, okay na?
okay na.
Okay.
Pa-on din daw ng video mo.
Okay, just do it later. I'll just finish this. Continue.
All right.
Okay. Okay, so let me just repeat for the slide. So majority of the thyroid cancer diagnosed right now are classified as well-differentiated thyroid cancer. Okay, so we all know that it's not that aggressive. It has an indolent course with excellent outcomes. You have high survival rates with low recurrence rates. So there's little evidence that early detection and treatment of these types of cancers would significantly alter disease outcomes. So what do we do? So in the current period of exceptional demand on the healthcare system, we know that priorities are realigned. And thyroid ultrasounds are classified as non-urgent. In fact, most scheduled procedures have been deferred to a later time when risk of exposure to COVID-19 is more manageable and resource restriction is no longer a concern. So what can we do? Okay, now we just have to explain to our patients, those we consider to have possibly a potential thyroid malignancy, about the tumor behavior. Okay, how it's not that aggressive, that any delay in the diagnosis intervention would really not affect overall survival. Okay, so we should reassure our patient of the disease course. Okay? Explaining, we should also explain to them the treatment modalities available and the timing of timing of performing procedures, okay, in relation to what is happening right now. So in summary, okay, so thyroid or neck ultrasound is used to differentiate benign from malignant thyroid diseases. Okay, there are 5 main features that we use to 5 main ultrasound features. Okay, that we use, okay, to consider malignant, whether a nodule is malignant or not. There are several scoring systems in existence developed by different specialty organizations, but standardization is still needed for that. And in these times, reassurance is needed until complete assessment of the patients can be performed. Okay. Thank you very much.
Thank you, Dr. AP, for that comprehensive presentation. No? So this is not urgent. We have to assess our patients. Okay. For the next lecturer, we have Dr. Roberto Sarmiento to talk on the impact of COVID-19 on thyroid cancer surgery.
Good morning.
Okay, sir. Good morning. You can go ahead.
Thank you very much for the privilege and invitation as one of the speakers today. Today, I'm tasked to talk on the impact of COVID-19 pandemic on thyroid cancer surgery with the following objectives: to discuss thyroid cancer surgery in the time of COVID, and then briefly to discuss the resumption of thyroid surgery post-COVID. Globally, there have been more than almost 4.5 million reported cases of COVID-19, resulting into more than 300,000 deaths. In the USA, which is hardly hit by the epidemic, almost 1.5 million have been infected, resulting to more than 85,000 related deaths. Locally, the Department of Health COVID Bulletin, dated last week, May 15, reported more than 12,000 cases of COVID-19, resulting to 806 deaths. Sadly, a lot of healthcare workers, doctors, and nurses were positive with the COVID-19 disease and died of the disease. On March 11, 2020, as soon as the WHO declared COVID-19 as a pandemic, the Philippine College of Surgeons issued immediately recommendations for the management of elective surgeries. To wit, minimize all elective urgent procedures, including cancellation of already scheduled surgeries and all other procedures such as endoscopy or interventional procedures. The Philippine College of Surgeons, through its Cancer Commission, also came up with specific guidelines on managing cancer care on specific fields. Immediately the following day, the Philippine Society of General Surgeons adopted the PCS guidelines, which was actually derived from the publications of the Society of Surgical Oncology on cancer surgeries in the time of COVID. In particular, endocrine and head and neck cancer surgery, which states that most endocrine surgeries can be most uncomplicated endocrine surgery operations can be delayed, and for thyroid surgeries, thyroid cancer that is current or impending threat to life, and those that are threatening morbidity with local invasion like involvement of the trachea, recurrent laryngeal nerve, those with aggressive biology, rapidly growing with rapidly progressive local regional disease, including lymph nodes, severely symptomatic Graves' disease that has failed medical therapy, or goiter that are highly symptomatic or as at high risk of impending airway obstruction. Lastly, open biopsy with diagnostic intent for suspected anaplastic thyroid cancer or lymphoma can be classified as emergent operations. This is a case which was shared to me by a colleague, which was operated January this year, pre-COVID, complaining of a huge thyroid mass with bleeding and infection. A debulking procedure was done, and the patient followed up in the height of the pandemic through the wonders of telemedicine. This is another case, this time a referral from a telemedicine referral from a colleague from Camarines Norte of a patient who presented with a large goiter, large thyroid mass presenting with airway obstruction. These two illustrative cases are exceptions to the rule rather, for these are emergent cases which mandates emergent surgical intervention. Updated publications on cancers emphasize the fact that with current evidence, cancer patients have a higher risk of infection and serious complications from COVID-19 relative to other patient subgroups. 95% of thyroid cancers are well-differentiated. Well-differentiated papillary thyroid cancers and follicular thyroid cancers represent 84% and 11% of all thyroid cancers, respectively. Medullary and anaplastic thyroid cancers account for the remaining 3%. It's good to note that well-differentiated tumors are highly treatable and curable. The natural history studies of these well-differentiated tumors demonstrated their slow-growing nature or indolence, tumor stability, and low potential for recurrence. This year, there's an estimated more than 50,000 new cases of thyroid cancer to be diagnosed in the United States, and only about 2,180 people will die of the disease. The 10-year relative survival for papillary and follicular cancers are 99 and 95% respectively, while the 10-year relative survival for medullary thyroid cancer and anaplastic cancer is about 70%. Okay. Anaplastic accounts, although rare, have a poor prognosis with a relative survival of 7% and accounts for 30% of thyroid cancer deaths. What are the direct impact of COVID-19 on thyroid cancer? On our patients, obviously there would be a delay in surgery. There would be fear of possibly being infected. There is a high risk of complications if operated. Of course, there will be anxiety and budgetary constraints. For us surgeons and other healthcare personnel, the lack of testing, inconvenience of wearing the PPE, you have misting of your goggles and eye shields, you will be losing your dexterity because of double gloves, you will be in time pressure to do your operation right away because of the risk of prolonged exposure to a possible COVID patient, the absence of our income with our clinics, and of course, the direct effect on hospitals. Loss of income would secondary to decreased admissions. You will be having manpower problems, increased costs of upgrading the operating room and ICU for safety purposes, and of course, the steady supply or availability of your personal protective equipments. Actually, the other loser in the fight against COVID-19 is the surgical training. Because of the delayed medical board examinations, in the average, there are 2,300 plus board passes per year, and these are prospective applicants for the 92 general surgery training program across the country. So if there are no passers, there would be no first year or no new applicants to the 92 accredited training programs. Also, we are expecting a decreased number of graduates in the 72 fully accredited programs because of failure to achieve the minimum number of index operations. There are no accreditation visits this year by the accreditation committee of the Philippine Society of General Surgeons. There are cancellations in the in-service training examinations by the Philippine Board of Surgery, although the Philippine Society of General Surgeons is planning to give our CERES exam online. Certain training programs already declared they will not graduate senior residents this year and will be freezing appointment for first year next year and the extension of appointments of the senior residents up to next year. The Philippine Society of General Surgeons Board of Directors and the Accreditation Committee is seriously studying on how to address these important issues. Here in our region, in Bicol Medical Center, which is the biggest government training hospital, COVID referral at that, and the Mother Seton Hospital, which is the biggest private training hospital in Bicol. They are both members of the Accredited Consortium for Education and Surgery, in which I am connected. I reviewed the 3-year data of our surgery on thyroid operations on head and neck from 2017 to 2019. We have our fair share of thyroid surgeries, averaging about 80 to 85 cases per year. And on the average, most of our senior residents, by the time summer is over, have accumulated the required index number of operations to qualify for eligibility in the PBS Part 1 examination. But sadly, beginning January 2020 up to the March 14 lockdown, with the cessation of elective surgeries, our current census revealed only less than 20 thyroid surgery operations. Okay? Clearly below the expected number of operations we see in the previous years. This is probably the same experience in other training institutions across the country. So how about reversing the trend and resumption of elective surgeries? As early as April 28, 2020, 30 states of the United States of America, in particular New York, which was hardly hit by the COVID-19 epidemic, have announced plans to resume elective surgeries. The American College of Surgeons immediately came up with post-COVID-19 readiness checklist guidelines for resuming surgery. And not to be outdone is the Philippine College of Surgeons, who came up with guidelines on post-ECQ resumption of elective surgeries and outpatient clinics. Our colleagues from the anesthesia, Philippine Society of Anesthesia, toed the line, coming up with post-ECQ guidelines for elective surgeries. And these are the summary of the recommendations of the three organizations. I will not dwell too much on the details, but these are the summary. May resume elective surgery when there is decreasing incidence of COVID-19 in your area, when there is availability of testing and PPE, there's an upgrade of the operating room and the ICU for safety purposes. There should be return of full manpower complement. There should be prudent scheduling of operations, such as spacing of operations, one after the other, and the prioritization of some operations versus other operations. Lately, the two biggest hospitals in Metro Manila, which were in the front line of the fight against COVID, boldly announced that they are already resuming surgical operations, selective surgical operations. So St. Luke's and Makati Medical Center have already announced that they will be resuming elective surgical operations and paving the way for our journey or road back to normalcy or the new normal. So these are my take-home messages. Most thyroid surgeries can be deferred or delayed because of their indolent nature. And as AP just mentioned earlier, the delay would not be affecting the prognosis. And there should be preparations for resuming elective surgery because of the 2 months backlog already of the cases. We would be anticipating an increased number of patients scheduled for operations. So I think this is my last slide. Thank you very much for your kind attention, and thank you from Bicol.
Thank you, Dr. Sarmiento, for um, emphasizing that most of these cases are not urgent and priority is still to protect. No, let's weigh the risk and also protect our healthcare workers. For the next topic, in case you would really have to do some procedures, no, to discuss on safety concerns in doing thyroid-related procedures, let's hear from Dr. Adrian Fernando.
Yes, good morning, Dr. Ida. Thank you for inviting me here and thank you for making me part of this meaningful event. So I'm Dr. Ian Fernando. Good morning. So before I move to the discussion, please allow me to mention just a short disclaimer that the contents of this presentation came from current up-to-date advisories and guidelines that are not intended to be interpreted as the standard of care and may be superseded, supplemented, or enhanced by the recommendations of government agencies, different hospital systems, and or other local and international medical societies. Again, all in the context of the evolving nature of the COVID-19 pandemic. I was asked by Dr. Ida to discuss the topic safety concerns on thyroid-related procedures. So we'll be dealing with this common procedures, mainly ultrasound, fine needle aspiration, and endoscopy. There might be some topics that I'll be skipping because it was already mentioned by the previous speakers. But the main question is, are these procedures really safe to do at this point? On the 20th of January 2020, WHO already announced that COVID-19 is already a public health emergency. And on the 30th of January 2020 in the Philippines, we had our first reported case. On the 13th of March, to reduce the exposures of patients, healthcare workers to COVID-19 and preserve limited resources, CDC has issued a national guidance order to cancel all elective procedures. Moreover, the greatly affected high-risk population, such as elderly people and patients with comorbidities, that includes cancer, cardiovascular diseases, hypertension, and diabetes, has a predicted mortality rate way higher than the general cohorts of patients infected with COVID. So that's roughly about 15 to 49% mortality rate compared to the other cohorts of 2 to 3% mortality rate. Now, except for the Philippines, okay, and since our local cases here since January to the implementation of the ECQ, until last night, we already had about 13,434 confirmed cases and 846 deaths. And it's really believed to be highly contagious with a reproductive number of 2.8, meaning one positive case may infect 2 to 3 more individuals per exposure, especially when we deal with the head and neck region. So generally, examination alone of the head and neck is considered already as high risk for transmission. That's why all societies, agencies, organizations were advised to review current circumstances of their local setting, at the rate of community spread and the case doubling time, and recommended that routine non-urgent appointments should be postponed to limit the chances of infection to patients, healthcare workers, and to everyone. Likewise, this also included postponing appointments for patients with benign diseases such as thyroid tumors, and in all instances, telemedicine was advised. Now, the transmission of COVID-19 remains the same. It's actually by droplet and direct contact. But the main reason why it really poses a threat to conduct such procedures in the head and neck is due to the so-called aerosolization. And these procedures are collectively called AGPs, or aerosol generating procedures. So this includes the following airway procedures like tracheostomy, intubation, suctioning of the mucosal surfaces in the head and neck, through using high-powered instruments, even electrocautery, without using other without using plume evacuators and closed suction systems. And I believe the government, the DDH, are aware of this. In fact, they actually separated hospital medical clinics from the dental and EEND clinics and provided the qualifier that those clinics should implement strict health standards. So let us look at how big organizations have responded to this pandemic. As mentioned a while ago by Dr. Sarmiento, the ACS through the AAO-HNS last April 2020 issued clear recommendations that for all head and neck procedures, that included the following. We need to delay all elective ambulatory procedures and go to telemedicine. We need to reschedule all elective and non-urgent procedures, and that includes FNAB, endoscopy, and ultrasound, and delay all elective surgeries and postpone routine dental and eye care visits. But last week they tried to change. They actually modified this, and changes in the recommendation that the risk continues for us and head and neck surgeons that we must include this risk in our decision-making process. And strongly, they also recommended that to provide only time-sensitive and emergent care, and this include both office-based and surgical procedures. So from the usual timeline of patients that consults your clinic to the time the patient has been managed after the surveillance, imagine the impact of this restriction to our basic phases of healthcare. I personally believe that we need telemedicine today for many reasons, but I also believe that it has limitations. So we can solely use it for screening patients, surveillance of post-op long-term patients with chronic conditions, and most importantly for risk stratification. Now in Canada, they had a priority classification, which is based on justice. Okay, it's used to as the essential principle, and they classified it as priority A, priority B, and priority C. But take note that the priority A, the critical, they have a qualifier that for you to be able to proceed to for surgery and management, it needs to have an effective treatment. Another framework, while very, very good and unique with the other framework of prioritization, is the one implemented in Stanford University, which is spearheaded by Dr. Michael Toth of the Department of ORLA-HNS in Stanford. They have 3 recommendations, and these are actually based on 3 risks. Risk for the patients because of the disease, risk of delaying the procedure, and the risk of transmission. And they have 4 classifications: the urgent, less urgent but low risk patient, and those case-to-case classification. Now for priority 1, for urgent cases, they have the thyroid cancers there, especially those that are big and those are aggressive thyroid cancers. And priority 2 are those that have less risk or low risk. Okay. And the case-to-case basis, wherein each cases will be applied for upgrading, and it will be approved by the medical director. Now, you see here that in divisions, so basically everyone in the field of head and neck surgery and head and neck oncology are really serious about this matter. But remember that most suggest to avoid unnecessary procedures, including unnecessary endoscopy, but still, no organizations have advocated that cancer care should be delayed. And also remember that all thyroid cancers are not the same. They are generally less aggressive and should not be compared with the usual head and neck squamous cell carcinoma group. Now, during this current period, some aspects of thyroid cancer services may need to be prioritized, where it is not possible to follow normal diagnostic and treatment pathways, and where investigations and treatment are different from the usual pathways. It is important to continue to be honest and open with your patients and keep good records. So the question is, should we request for an ultrasound right away? Now, it actually depends. It depends on a lot of factors. Specifically, it depends on your clinical evaluation and the risk stratification, the disease burden in the area. Like if you will compare Metro Manila from probably Masbate and Romblon with almost 1 or 2 or 0 reported cases for over the past month, okay, and the capacity and preparedness of the center. Again, always manage patient based on the risk group analysis and the overall risk of progression to life-threatening issues. So if you think that it is benign or low grade, okay, like a small anterior neck enlargement or a big thyroid that has been existing for 20 years, you can delay and reassure the patient. And if the burden is low, the institution is not overstretched, and all safety measures are in place in your hospital or in these institutions, yes, you can proceed with the ultrasound. Now, the good thing, like what Dr. Dijos mentioned, getting an accurate ultrasound will help us plan better for our patients. It will help us make better decisions by more or less providing us with well-accepted sonographic risk evaluation, which actually leads us to the next question. Is it safe to delay FNA or thyroid nodules? Everyone is advocating to delay unnecessary or non-emergent cases. Again, take note that most thyroid nodules are benign, but some nodules of a certain size with the suspicious features on ultrasound may be advised to undergo biopsy or a fine needle aspiration. So in most cases, yes, you can proceed with the FNA, but please be guided with the clinical evaluation and the risk, the sonographic risk, and of course, it all depends on your patient's anxiety. Now, the HALIO, which is a thyroid society, says that most fine needle aspiration procedures for thyroid nodules can be safely delayed for 6 months or longer, but they qualified it that you can delay it, the vast majority, but you have to refer patients who are suspected to have medullary thyroid carcinoma, or those that are suspected with anaplastic carcinoma, or those FNA with urgent when is needed when the calcitonin level is equivocal. Now, is it safe to do endoscopy today? No. So you have to use it judiciously. There are already so where's the really when there's really an absolute need for it, like for patients with preoperative findings that there is already hoarseness to begin with, there's already aspiration to begin with, or in a post-op patient with hoarseness, or there's a big risk to injure the nerve about the substernal extension, yes, you can do it. Now, when you ask to review the hierarchy of control, you look at this. Vaccine medicines and HVAC systems are all on the top priority controls, but these are actually the ones that are not yet available up to today. Okay? So we have to maximize telemedicine. Okay? We have to maximize to eliminate the risk and substitute the risk, and have a strong administrative control. You look at the PP, it's actually in the lowermost portion. Now, the HVAC system can be used, but you have, if you're performing any aerosol generating procedure, having an isolated room can be used. In this absence, you can make use of portable HEPA filters with a goal to recirculate the air exchange to about 12 air changes per hour. But you also have to take note that it works when you configure the room, the type of furniture, the persons in the room, all of this must be considered. Also, when you're buying commercially available HEPA filters, you have to take note that these HEPA filters were not computed for 12 ACH, but only for 3 to 5 ACH. So you need to look at the manual and look at the CADR, or the clean air delivery rate, and you compute it based on the floor area and the ceiling area, or the area in the room. Now, take note that no air purifier or single system can actually save you from getting the infection. So in summary, you always consider the three different risks. Okay, so these are the risk of the patient from the disease, the risk of the doctor from having the disease or being infected or communication, and the risk of delaying the procedure. So you also have to communicate with your patient, and you have to educate them and give and tell them why there's really changes in your plan. You have to communicate with other specialists. Create the creation of prioritization protocols in your department cannot be done in a single department. It has to be multi-specialist. And then you do procedures judiciously, only when they are absolutely indicated, and always create an individualized patient care. Lastly, you need to ask yourself, how is the local burden in your area? Is your center already ready or prepared? What the administrative measures, the engineering measures, the training of your staff, the availability of the manpower? You ask yourself, is it really necessary? If yes, go ahead. If not, you delay and explain to the patient. And also ask yourself, what have you done to prepare for this pandemic? So lastly, we might have many different guidelines, but you have to take note that COVID-19 has not changed the indications for surgery. COVID-19 has not changed the indications for all these procedures. What has changed is actually the timing and the stratification. So in this COVID-19 pandemic, the major risk of our patients is actually not the virus, but the inability to receive necessary medical services, both in terms of getting to the hospital and providing them with the normal and standard care. So I think that's my last slide. Thank you for your kind attention.
Thank you, Dr. Fernando. That is the beauty of sharing among the different specialties. And for the succeeding lectures, we will be hearing from our friends, the non-surgeons, which are also essential in the management of thyroid conditions. So next is Dr. Wenceslao Lauderes to discuss on the effects of delaying post-operative RAI and how to mitigate its possible effects. Dr. Lauderes.
I think we can proceed to the next speaker muna. Ano?
Okay. So, okay. While waiting for Dr. Lauderes, we would like to hear from the president of the Philippine Thyroid Association, Dr. Nemencio Nicodemus, the impact of COVID-19 pandemic on the post-operative management and surveillance for thyroid cancer.
Thank you very much. Allow me to share my screen. Before I begin, I would like to thank of course, the organizers of this joint webinar. It is indeed a very important collaborative webinar wherein we all talk about the same disease entity, thyroid disorders, all of us dealing with this disease. For my part, I was tasked to share with you the impact of the COVID-19 pandemic on the post-operative management and surveillance for thyroid cancer. Over the next 20 minutes or so, we will try to discuss three very important issues that are relevant during this COVID-19 crisis. One, how do we identify patients who just need post-operative TSH suppression without additional therapy? Two, how do we identify patients who do not need frequent laboratory testing and frequent drug dose adjustment? And three, how do we identify patients who do not need more frequent follow-up? These three issues are relevant during this particular crisis because our overarching concern is to reduce the exposure of both the patient and the healthcare provider to the potential SARS-CoV-2 affected individuals. And therefore, if we can reduce the frequency of monitoring, if we can reduce interaction that would actually reduce our exposure to this particular virus. Since my particular task is to look at the situation after surgery or thyroidectomy, this will be the decision fork that we are going to look at. After total thyroidectomy, with or without neck dissection, we now proceed with our surveillance and maintenance. And we can classify patients either as those with gross residual disease in the neck after surgery, or those with no gross residual disease in the neck. For those who still have residual disease, of course, we can classify them either as those who have unresectable disease or those with resectable disease. And for those who are unresectable, we monitor these patients using our laboratory parameters such as our TSH, thyroglobulin, and even our anti-thyroglobulin. For those who are resectable, of course, we need to refer them to our surgeons for resection, and at which time they can be reclassified either as still having gross residual disease in the neck or no gross residual disease. After all of this, our next step would be to either administer radioactive remnant ablation of the iodine 131 or to give them other modalities of treatment. And so we can classify our patients as those that either would need radioactive remnant ablation or external beam radiation therapy or even our tyrosine kinase inhibitors. But after all of this, it is still important that we give these patients levothyroxine for thyroid suppression therapy. The first question and the issue that is relevant at this time is how do we identify patients who just need post-op TSH suppression without additional therapy? And so after your thyroidectomy, who are these patients who are better just given levothyroxine, suppress their TSH, and then just follow them up without additional treatment? It is at this point that we need to review the American Thyroid Association stratification system for risk of recurrence, and this will include considerations of the following parameters: the histologic subtype, presence of perithyroidal soft tissue invasion, the tumor resection, and even the presence of local or distant metastasis. And if we are going to classify the different the recurrence rate of our patients based on these parameters, we can classify them either as having low risk, intermediate risk, or high risk for recurrence. And as you can see here, certain histological subtypes are considered low risk, and this will include your papillary carcinoma, particularly those with no vascular invasion, and follicular carcinoma with capsular invasion, and also our papillary microcarcinoma. What will make them intermediate risk if there is the presence of vascular invasion, aggressive histology, and even extrathyroidal extension? Of course, any form of a vascular invasion, in that case, particularly for follicular carcinoma, will make it high risk. And it is important that we consider, of course, perithyroidal soft tissue invasion, because the presence of even just microscopic invasion in the perithyroidal tissue would already make it at least an intermediate risk. And the resection would be very important, of course, because if all macroscopic tumor are resected, that will make it low risk for recurrence. And of course, if there's incomplete tumor resection, that would make it high risk. As far as metastases are concerned, metastases to the neck are considered intermediate risk, and distal metastases are considered high risk. So after we consider the patient's risk post-thyroidectomy, then we decide, are these patients now going to need adjuvant radioactive iodine ablation? And based on this most recent recommendation, you can see that those patients who are low risk for recurrence may not even need radioactive ablation. and therefore may just be suppressed with levothyroxine, whereas those who are intermediate risk and high risk would definitely need radioactive remnant ablation, be that the low dose or the high dose radioactive iodine treatment. So the question now is, if we are to give our levothyroxine to suppress TSH, what would be the appropriate initial TSH suppression for our patients with thyroid cancer? And again, it is here at this point that we consider their risk of recurrence. If our patients have a very high risk for recurrence, we should suppress the TSH to below 0.1, of course, using our levothyroxine. If our patients are of intermediate risk for recurrence, we will now suppress the TSH to levels between 0.1 to 0.5 milli-international units per liter. And if our patients are just low risk for recurrence, there is that option for us to just relax our TSH suppression. In fact, you can even make it within the lower limit of normal between 0.5 to 2 if they have no thyroglobulin, or if the thyroglobulin is not seen, and if they have low thyroglobulin and they underwent radioactive remnant ablation, you may still suppress their TSHs, but just between 0.1 to 0.5. And for those who underwent lobectomy, because as we know in the United States, there is that particular option for lobectomy, even for thyroid cancer, the recommendation is just to relax the TSH suppression to between 0.5 to 2. So you can see here that if your patient is of low risk with almost zero thyroglobulin or very, very low levels of thyroglobulin, then you just need to give your patients enough levothyroxine to aim for a TSH between 0.5 to 2, and that would mean that you don't need to see your patients very, very often, unlike those with intermediate to high risk, wherein you need to up-titrate your levothyroxine regularly in order to achieve this particular suppression of TSH. So the clinical decision making now for our differentiated thyroid cancer is that after we administer our initial therapy, of course, and that would include surgery, we evaluate the post-operative disease status of the patient and assess, of course, the risk for recurrence. And we decide now, depending on the risk of recurrence, whether we will administer radioactive iodine treatment and subsequently suppress the TSH as we have discussed in the previous slide. However, we know that we must also still continue to monitor these patients and evaluate their response to therapy. And this is where our second issue comes in. How do you identify now patients who do not need frequent laboratory testing and any drug dose adjustment? And here, we look at the different categories of response to treatment. After your patient has undergone surgery and radioactive remnant ablation, you can now categorize your patients depending on their responses as follows. One, biochemical incomplete response, which means that they have negative imaging, their suppressed TG is more than 1, their stimulated thyroglobulin is more than 10, and or they have rising anti-thyroglobulin antibody levels. Secondly, they may fall into the category of structural incomplete response, wherein they have structural or functional evidence of disease with any level of thyroglobulin with or without anti-thyroglobulin antibody. So the presence of structural or functional disease would make it a structural incomplete response. Of course, in contrast to the biochemical incomplete, wherein it is negative on imaging and just present on thyroglobulin or anti-thyroglobulin levels. But your patients may also fall into these better categories. Of course, those with excellent response. And an excellent response to treatment would be defined as negative on imaging and the suppressed thyroglobulin is very low, less than 0.2, or if it is stimulated thyroglobulin, it is less than 1 nanogram per ml. And if your patients after thyroidectomy and radioactive remnant ablation possess these characteristics, then we consider them as excellent response. Of course, somewhere in between, you have your patients who present to you with indeterminate response. So having said that you have patients who would fall into these 4 categories of response to treatment, what would now be our next course of action? If our patients have structurally incomplete response, then you must suppress their TSH to below 0.1 indefinitely. If your patients have biochemical incomplete response, which means on imaging it's negative, but their TG and anti-TG are seen and elevated, then you must suppress their TSH between 0.1 to 0.5. And if your patients fall into the category of excellent or indeterminate response, if they are high-risk disease based on our initial assessment for recurrence, then you can suppress their TSH between 0.1 to 0.5 for the first 5 years, and then you can relax a little bit on their suppression. And those who present to us initially with low risk of recurrence and on follow-up, they present to you with excellent response to treatment, then there is an option to just maintain the TSH between 0.5 to 2. So indeed, over the last couple of years, our understanding and even our recommendation as far as TSH suppression has really changed. When in the past, most of us would really suppress the TSH to below normal levels, to all of them to below 0.1, now there is that particular recommendation to relax on your TSH suppression depending on your initial assessment of recurrence and depending also on your evaluation of their response to treatment. Now let's go to the third issue relevant during this COVID crisis time. How do we identify patients who do not need more frequent follow-up? And of course, these would be the patients wherein you don't need to suppress their TSH so much. And this particular table summarizes the factors that are important for us to consider whether we will suppress the TSH to very, very low levels or we would just be more relaxed as far as our TSH targets. And of course, we all know that there are risks that are involved with TSH suppression. And that's the reason why we must relax on some of our TSH targets depending on the presence of these different conditions. Menopause, of course, the presence of tachycardia, osteopenia, the age of our patients, the presence of osteoporosis, and even atrial fibrillation. Of course, if your patient has an excellent response to treatment, which we have already defined a while ago, and as we mentioned, our target TSH for these patients would be between 0.5 to 2. And that will now take care of the risk that your patient will go into further tachycardia or you will further worsen their bone function, particularly in the elderly and those with atrial fibrillation, since we know that very high doses of our levothyroxine would even predispose to tachycardia, atrial fibrillation, and even osteoporosis. For our patients who are defined as having intermediate response to treatment or even biochemically incomplete response, then, as we mentioned, the TSH target could be much lower, 0.1 to 0.5 milli-international units per liter. And for those of our patients who have structurally incomplete response, and therefore there is really residual disease among these patients, then there is a need for us to do moderate or complete suppression, aiming for a TSH target that is less than 0.1 milli-international units per liter. And so indeed, in the present time, we must identify our patient's risk for recurrence. We must define our patient's response to treatment because that will also tell us what TSH target we should be aiming at, and therefore the way we adjust our levothyroxine treatment and the frequency of follow-up will also be dependent on such. Just to put them all together, our TSH suppression therapy targets based on the risk of recurrence and the response to therapy would therefore fall into 3 categories. Just remember, it can be either less than 0.1, between 0.1 to 0.5, or between 0.5 to 2. Just these 3 categories. If your patients are at high risk for recurrence, have structurally incomplete response, aim for TSH suppression less than 0.1. If your patients on the other extreme are very low risk with almost negligible thyroglobulin and they have excellent or indeterminate response based on your assessment, then you may continue levothyroxine with the aim of TSH between 0.5 to 2. And of course, those that are in between will need TSH suppression between 0.1 to 0.5 milli-international units. So just 3 ranges to remember, and just these categories that we must always put at the back of our minds when making clinical decisions. And if we are to put that in an algorithm that was nicely put by the NCCN, so after the initial surgical treatment, we assess their risk for recurrence, and then we of course give them radioactive iodine therapy depending on the need, and then we assess their response to treatment, whether it be excellent, incomplete, or even biochemical incomplete, structural incomplete, or indeterminate. And as such, you give now your levothyroxine to suppress to different TSH goals. And so to address now the 3 issues that I began and that I put forth when I started this particular session. How do you identify patients who just need post-operative TSH suppression, perhaps without the need for additional radioactive iodine treatment? How do you identify patients who do not need frequent laboratory testing? And how do you identify patients who do not need more frequent follow-up? The answer to the first issue, these are the patients who are of low risk for recurrence. And therefore, after thyroidectomy, they may just be perhaps given levothyroxine with the appropriate TSH suppression. Those with excellent response to total thyroidectomy and radioactive remnant ablation may not need frequent laboratory testing with thyroglobulin or even TSH. In fact, because your TSH levels may not need to be suppressed very much and may just be between 0.5 to 2. And finally, if you put together patients with low risk for recurrence and excellent response to treatment, they are the patients who perhaps you can advise not to go back to the clinic more often, and therefore, in the end, we will be able to achieve our overarching concern to reduce our exposure to the SARS-CoV-2 virus. Thank you very much.
Thank you, Dr. Nemi, for that very clear and comprehensive presentation. I think our surgeon participants would really appreciate the lecture.
Ida, I think Dr. Lauderes is here na.
Dito na. Okay, so to bring back Dr. Wenceslao Lauderes to discuss delaying post-operative RAI, how to mitigate its possible effects.
Okay, good morning. So it is really an honor to be a part of this webinar activity. So my task is to give or to present our options, our strategy, just in case we are delaying post-operative radioactive iodine 131 and how to mitigate its possible effect. So just for a quick review for differentiated thyroid cancer, so basically this carcinoma comes from follicular epithelium, basically papillary and follicular type. Though the prognosis is good with an overall survival rate of about 85%, but there's really an issue of recurrence as far as differentiated thyroid cancer is concerned. And I'm part of the management also for differentiated thyroid cancer is its capacity to respond to the radioactive iodine therapy. The sodium iodide importer in the follicular cell is actually responsible, for the radioactive iodine therapy to be able to pass through, and go into the follicular cells to deliver its radiation dose. So the role of post-operative RAI ablation is really to destroy residual thyroid tissue and to decrease the risk for the recurrent regional disease. And also it facilitates long-term surveillance, monitoring with whole body scan and with thyroglobulin measurement. So radioactive iodine is one thing that's very nice for the radioactive iodine 131, and other than therapeutic purposes, the RAI 131 is also used for diagnostic. And radioactive iodine 131 decays by emission of beta particles in gamma rays. If we're talking about gamma rays, this is usually being used for the diagnostic purpose. And for the decay particles, this is usually the reason why we are delivering therapeutic indications for patients with differentiated thyroid cancer. The physical half-life of iodine 131 is about 8 days, and it's the beta particles that are responsible for delivering the indicated therapeutic radiation dose for the remnant thyroid tissue. So for us to give the RAI, we should have at least a hot lab zone. And then the RAI is basically a capsule form. And if the patient is scheduled for the specific indication for therapy, this is the dose calibrator machine that defines specific radiation delivery to the patients. So what is the pathophysiology of ablation? So it's the ionizing effect of beta particles that includes necrosis of follicular cells and consequent vascular occlusion, which eventually develop over a period of time after the intake dose. The chronic inflammation, the subsequent fibrosis, and the atrophy of the particular follicular cells. Hence, it is followed by shorter survival and impaired replication of surviving cells, leading to death. So if we're talking about RAI ablation, it basically defines the destruction of residual macroscopically normal thyroid tissue following surgical thyroidectomy. Though there are a lot of controversial issues on giving the RAI, some say it is beneficial, some say it is not. But we have a lot of studies also that will defend the significant benefit of giving RAI. Okay? There are some also says, on the other hand, that RAI does not give beneficial effect to the patient. But this will boil down to risk stratification of the patient, the histology of the patient, presence of METs with aggressive histology, and issues also of capsular invasion. So RAI is recommended to those patients classified with intermediate, including high-risk patient. Though the issues of the beneficial effect of radioactive iodine is still controversial as far as low-risk patients are concerned. In this image, you can see here that RAI really play a significant role, not on the overall survival rate, but basically on the recurrence rate of the patients having differentiated thyroid cancer. This is an example of an actual thyroid patients with differentiated thyroid cancer. So after giving a radioactive iodine, you can appreciate here post-thyroidectomy and after undergoing radioactive iodine that lung mets is well appreciated in this image. And 3 days post-therapy, there is really good resolution and avid intake of the radioactive iodine. And after 6 months of post-therapy, you can be able to appreciate the beneficial effect of ablating distant metastasis of this patient. So the decision of RAI ablation must be, of course, individualized, also based on the risk profile of the patient as well as patient and physician's preferences, while at the same time balancing the risks and benefits of such therapy until last January 30, 2020, that World Health declared that COVID-19 outbreak is already a public health emergency of international concern, and last March 11 is already classified as global pandemic. So what happened? So the problem with the patients scheduled for radioactive iodine at that particular time when enhanced community quarantine had been declared, there is no available isolation rooms. All isolation in private rooms of government hospitals converted to COVID wards. Nuclear medicine facilities were closed, and of course, no available radioactive iodine from suppliers. And our dilemma at the time is patients had been prepared for the procedures. Usually, if we prepare patients for radioactive iodine, we usually instruct them to stop thyroxine replacement, and usually for 4 to 6 weeks, depending on the TSH level. And the guidelines usually is as long as the TSH level reaches 30 or more than 30, is already a good indications that the patient will be subjected for radioactive iodine. Okay, so but at that particular time, we advise the patient to indefinite suspension of radioactive iodine 131. And our problem at the time, patients had been complaining, really had been complaining, actually some really appealing to us because they already presenting with overt hypothyroidism, swelling, including depression, okay, weight gain with severe body pain, and bouts of chest pain. So our dilemma at the time, how can we be able, if delaying the radioactive iodine can be able to help the patient, or if delaying the radioactive giving or administering radioactive iodine can be able to further complicate the existing problems of the patient having been off with the thyroxine replacement. But there are a lot of studies to date. There is still no consensus regarding the timing of adjuvant radioactive iodine therapy, or if the timing of initiating early RAI affect the clinical outcome. Some basically I've run through 3 articles, and all of them, for example, in the study of Sheffield, of timing of radioactive iodine administration does not influence outcome in patients with differentiated thyroid cancer. Actually, there were about 545 DTC cases. All were undergone subtotal and total thyroidectomy. And the cutoff period at the time was less than 6 months. Less than 6 months considered as early RAI, and more than 6 months considered as delayed RAI. But the results showed that the timing of radioactive iodine therapy relative to the thyroidectomy did not alter disease outcome in thyroid cancer. This holds true also with the study of Paritos, Wang, and Winchester among low risk and intermediate risk papillary thyroid carcinoma. The results also showed that patients given an RAI less than 3 months and more than 3 months did not show significant differences as far as overall survival rate of the patient, both low risk, including high risk papillary thyroid carcinoma. So what our options in this particular pandemic crisis? So we instructed the patient to still, of course, continue or resume thyroxine replacement. No? That's the best that we can do. That's the best we can offer to our patients to minimize or improve the overt hypothyroidism they've been experiencing for a lot of how many weeks, including months already. But during that lockdown, the last week of March, the Philippine Society of Nuclear Medicine made a letter addressed to Philippines Society, made a letter to Philippine Nuclear Research Institute through their director that if we will be given, because there are still issues of availability of isolation rooms, nuclear medicines, hospitals cannot still accommodate patients even for an outpatient cases. If the cancer patients classified as high dose therapy to be done as outpatient procedure, because currently patients undergoing low dose intended for the hyperthyroidism can be an outpatient service, whereas patients more than there's an existing guidelines in the PNRI that those patients subjecting for high dose for cancer patients will be admitted in the hospital for a certain period of days, and after a certain period reading of radiation reading that conforms with the standard can be able to, that will be the time that they will be discharged. And in the old CPR, if we're talking about CPR, this is actually the CPR for the Philippine Nuclear Research Institute. CPR means Code of PNRI Regulation. The old CPR stated here that you cannot discharge patient as long as this did not meet the corresponding radiation reading. But in the new CPR, we can release patients, we can release patient as long as the recommended dose requirement is not to exceed the 3 millisievert. So how can we be able to translate this? Of course, this computation had been done by our physicists, and I cannot explain this in details because this had been actually reviewed and formulated by our physicists. But basically, if the patient can be able to provide a documentation that they can be able to meet at least seven requirements, to the distance of 4 meters away without wall, or 2 meters away with wall, to isolate self from others for at least first 3 days. They can be able to sleep alone in a room for at least the first 2 nights. We will not travel by airplane or mass transport for at least 3 days, travel on prolonged automobile trip less than first 3 days. With all these indications or parameters set by our physicists, we can be able to do the radioactive iodine therapy for those cancer patients, high dose, labeled as high dose, in an OPD setup. This is actually a screenshot by the PNRI giving us the go signal that we can be able to do the radioactive iodine therapy for cancer patients already as an outpatient, in an outpatient basis. Okay, so how to mitigate this? If we can be able to apply this new setup, at least this can be a big help to those patients that had been lobbying for us to push the indicated radioactive iodine therapy to those patients labeled as cancer patients having differentiated thyroid type. With this, thank you so much.
Thank you, Dr. Lauderes, for that lecture. And we have one more lecture now, because aside from thyroid cancers and nodules, we might encounter cases of hyperthyroidism in practice. So to discuss on the options in managing hyperthyroidism during this time, let us welcome Dr. Jeremy Robles, President of the Philippine Society of Endocrine, Diabetes, and Metabolism.
Hello, good Morning pa po sa lahat ng tao. Thank you so much for inviting me to speak for this particular SIMPO. No? I'm very glad to join everyone and share the knowledge with regard to hyperthyroidism. So my talk for today basically will cover options in managing hyperthyroidism at the time of COVID. So I'm actually broadcasting here in Cebu right now. So we are also faced with our own challenges with regard to the management of COVID. And therefore, I think this is a very important topic to everyone. So the outline of the talk pretty much covers the following topics. First, I'm going to talk about prevalence of thyroid disease and hyperthyroidism here in the Philippines, management of hyperthyroidism pre-COVID, then peri-COVID time management, issues on COVID-19 and hyperthyroidism, and we'll run through some of the recommendations as well as clarifications of many of the experts all over the world. So I'll do my best to summarize everything. So I'll end up with the key points and perspectives as far as these two topics are concerned. So generally in the Philippines, the very common or the usual reference that we use is the Philippine Thyroid Disease Study or the Field-TIDE studies. This was actually published sometime in May 2012. We're planning to do another one, but I think even then we realized that thyroid disease was already a very significant problem here in our setting. In 2012, we know that the prevalence for thyroid dysfunction in the Philippines is already 8.53. Just to note that the current diabetes problem here in the Philippines is pretty much close to 8% also. So it is a fairly significant disease entity. Half of the hyperthyroid patients actually present with goiter, and typically the thyroid function tests are the ones that actually give them out. So let's look at some of the data that we have for these patients. When they did field tides, they looked into the status of about 4,480 patients. So ito po yung mga respondents for this particular study. So they examined them clinically and they did lab tests. So for subclinical hyperthyroidism, 258 or 5.33% of the patients had subclinical hyperthyroidism. So ibig sabihin nito, yung TSH went down a little bit, but the FT4 and FT3 were still within normal range. Those that had overt hyperthyroidism or true hyperthyroidism, only about 30 or 0.61. But I always say that this number of patients does not really reflect the significance of thyroid disease, especially hyperthyroidism. When you talk to these patients, they're really affected and because of this disease entity. And it's quite obvious for some, and some maybe because they're subclinical, may not be manifesting it fully. So here is the profile of our patients. If you see here, the column that's in green shows the normal patients, normal thyroid function test. Typically, among the population, we had a 43-year-old average. Female to male ratio was about normal, 1:1. The mean FT4 was 1.05 nanograms per DL, mean TSH 1.9. This was considered normal for the study. Compare this with the true hyperthyroidism. You notice that it's an older age group. The average age about 51, with a range of 45.5 to 56.5. It now is predominated by females, 23:7. No? Then the mean FT4 is 2.77, definitely higher than the normal FT4. And you have a very low TSH of 0.1 compared to 1.9. Note that in the subclinical hyperthyroidism column, you will see here that the ratio is a little bit more even compared to that of overt hyperthyroidism. And if you notice also that the FT4 is actually within range, but the TSH is slightly lower. Okay. So in 2016, this is our reference point, no? The American Thyroid Association guidelines for the diagnosis and management of hyperthyroidism. So in the US, the prevalence is only about 1.2%. Actually, if you think about it, mas mataas pa yung sa Philippines. No? Most common causes still is Graves' disease, followed by toxic multinodular goiter and toxic adenoma. Graves' disease autoimmune is actually a disorder that is characterized by elevated levels of thyroid-stimulating hormone receptor antibody, and we'll talk about that a little bit later. Okay, so here, you know for a fact that Graves' disease is not the only cause of hyperthyroidism. You know that you have several other causes that will manifest with normal or elevated RAI uptake on the neck, and also those that have near absent RAI uptake on the neck. No? So yung mga thyroiditis, okay, these are the ones that will have absent RAI. You also have factitious ingestion of thyroid hormones through ovary and metastasis from follicular thyroid CA. But mainly the discussion today will focus on Graves' disease. Okay, so approach to hyperthyroidism. In 2018, the European Thyroid Association guideline for the management of Graves' hyperthyroidism was actually published. The approach is pretty much straightforward. You do lab tests and the TSH will show you that it will be suppressed. Then you check for your FT4 and FT3. If it is overt hyperthyroidism, you will notice that together with a suppressed TSH, you have an elevated FT4 and FT3. You have a T3 toxicosis if only the FT3 is elevated and you have normal FT4. That's why we always tell our trainees that, you know, when you suspect that this patient is hyperthyroid and yet you look at the FT4, which is normal, and you have a suppressed TSH, there's a possibility that this is a T3 toxicosis. We touch a little bit on subclinical hyperthyroidism, and this is characterized by low TSH with normal FT4 and FT3. The clinical significance is eventually some of these patients will become overt hyperthyroidism. So sometimes you will have to follow them up closely. So as far as serology is concerned, and we're talking about Graves' hyperthyroidism, the TSH receptor antibody is one of the more important serologic tests that you might want to do to confirm Graves' hyperthyroidism. The ultrasound still has some utility. Most of these patients, okay, will manifest with some sort of goiter or enlargement of the thyroid gland. So I think it's part and parcel of the diagnostic workup that you include the ultrasound. So here you have the pharmacologic options that you may use for hyperthyroid patients. And I put this table here so that we can touch briefly on the profile of these two medications. In the Philippines, we have methimazole and PTU. Methimazole in the UK is available as carbimazole. So let's look at the profile. So methimazole, both methimazole and PTU are very rapid as far as absorption. They're very well absorbed with a 100% bioavailability. They usually peak in an hour, and the half-life, methimazole longer or up to 8 hours, but PTU only an hour and a half. Okay, so turnover for methimazole is slower compared to PTU, and the duration of action of methimazole also longer compared to PTU. So methimazole can cross the placenta, and it is also increased in breast milk. So that's one very important point that we consider when we're dealing with pregnant patients that are hyperthyroid. So initially we use PTU in the first trimester, and then second and third trimester, we kind of shift these patients to methimazole. So as far as excretion, both of them are renally excreted. Potency, methimazole is more potent than PTU. The normalization of T3 and T4 is expected within more or less about 6 weeks on patients treated with methimazole, a little bit longer with PTU for about 12 weeks. We do have adverse events for both of these medications at about 15 to 20%. So what are these adverse events? Sometimes you have allergic reaction that is manifested in the skin. Sometimes you have a more severe side effect, which is agranulocytosis. So considering MMI and PTU, PTU has increased risk for agranulocytosis at 1 to 1.5%, while that of MMI is only 0.6%. So in terms of compliance, a lot of the patients prefer methimazole because they only take it once or twice a day, whereas in PTU, you take it 3 times a day. So cost, fairly about the same. So here, I'm just summarizing everything that we have been using in terms of treatment of hyperthyroid patients. So in the initial phase, we usually use beta blockers, mainly for the sympathetic manifestations of our hyperthyroid patients. We want to be able to control the tremors, the palpitations, and then we also start them on antithyroids. Later on in the management, when we pursue a definitive treatment, the options now are directed to either radioiodine therapy or you go for thyroidectomy. These are viable options that are presented to the patient. So looking into the management of hyperthyroidism, I summarize here basically this table I got from the 2016 ATA guidelines. So if you look at here, you will see the different clinical situations of which your patient may be presenting with. So the three main management as far as hyperthyroidism, as we know, is only radioiodine, antithyroid, or surgery. So it seems here it's a little bit skewed. No? If you look at it, radioiodine seems to be the preferred for a lot of the clinical situations that our patients are hyperthyroid with. Antithyroid drug still remains a very good option. But we always say that this is only to stabilize the patient before we put them into a more definitive treatment. So surgery remains a viable option, particularly for those with very large thyroid goiter or very enlarged thyroid gland. Okay, so we have several nodules that are present on these patients, or if there are also other patients presenting with periodic paralysis. No, so these are the points that favor surgery for these patients. No, so here, obviously, during this time when they came up with this recommendations, there's no recommendation for any pandemic with regard to some sort of virus, no, at this time. So this is pretty much what we did before COVID actually came. So patients underwent radioiodine, we pre-treat them, we give them methimazole or PTU, and then we withdraw the methimazole or PTU 3 to 5 days prior to radioiodine therapy. And then we continue the medications, the comorbid medications that were given to these patients are continued prior to the radioiodine. And then after radioiodine, we resume the medications after a week. The typical follow-up will be post-RI, about 1 month. And then we do again the test, the FT4, total TT, TSH. And then the intervals is 4 to 6 weeks. So roughly about a month until we reach about 6 months post-radioiodine, when then we start to taper every 3 months or if possible every 6 months. So this has been always the approach for hyperthyroidism. So during COVID, the problem is we're limited now, as what was discussed earlier by the previous speakers. Radioiodine is not an option at the moment because of limitations that we have for obvious reasons. Thyroidectomy is a relative option for us to consider for those that are extremely hyperthyroid. And even the antithyroids have also things that we need to consider. And I'm going to cover all of that. No? So beta blocker still is a good choice to control the symptoms of these patients. But as I said, COVID disrupted everything. So let's touch a little bit about COVID. No? So we all know this. This has been shown earlier. COVID, more than 5 million affected, more than 300,000 affected. And this is the local implications. The Philippines has a case fatality ratio of about 6.47. And this is at par with global case fatality ratio, which is 6.64. Of course, leading the way now is UK with 14.2 and Italy with 14.19. We're almost about the same with the United States. And Indonesia, in the ASEAN region, Indonesia is also very close to the Philippines. But we envy Singapore and Vietnam that until now do not have any mortality, or at least have very low levels of mortalities. So this is a new era for healthcare. So what are the problems that we are encountering? These were mentioned already earlier. Community quarantine, restrict movement of people. The priorities have changed. It's been COVID-19 directed. We have limited surgical and nuclear medicine procedures. Outpatient clinics are closed, no access to healthcare providers. What are the solutions that have actually come out because of this COVID dilemma. Telemedicine and e-health solutions are now being done by a lot of the healthcare providers. Global initiatives are being done also to find the cure, or not, if not the vaccine that we need to actually control COVID. And then social consciousness and heightened awareness as far as infection control is concerned. These are still very important aspects of the management of the global pandemic of COVID-19. So obviously, there is limited data on thyroid management during COVID-19 pandemic. The reason for this is that this is fairly new. We have no idea how this thing started. No idea, in a sense that we're not sure if it's actually started with just this zoonosis that was transferred to humans, or if there's anything else that have actually caused it. The fact is, it is a virus and it affects a lot of people. It's very deadly. And we know that this spreads so fast that even the best of our doctors still are struggling as far as managing this disease is concerned. So let me try to answer a lot of the issues that were raised through the experts all over the world. So the British Thyroid Foundation actually came out with a resource paper addressing a lot of the issues of hyperthyroidism. So here are the important questions that we all need to know. So are individuals taking antithyroid drugs at higher risk of infection? Actually, antithyroid drugs are not known to increase infection. So even if these patients have neutropenia, which is very rare, you should not stop your antithyroid medications. No? So unless there is a compelling reason, sort of toxicity that is being manifested by the patient. And this will entail that these patients be seen by a medical, a doctor or a specialist that will look at them, and then they will assess them. No? The symptoms of neutropenia with sore throat, mouth ulceration, fever, flu-like illness is very similar to COVID-19 infection, which will present also with fever, continuous cough, and flu-like illness. As I said, it's a doctor's discretion if you will do COVID test among these patients. But of course, if the symptoms will worsen, you're gonna have to do a full blood count. Okay, in some cases, antithyroid medications will have to be stopped and restarted a week to check if the symptoms actually improve. Some other questions that were raised: how should blood testing be performed for individuals on treatment of thyrotoxicosis? Now, for obvious reasons, a lot of our patients are not able to go to the laboratory or to the hospital because they're either anxious or they're scared, or outright, these medical facilities are not prioritizing these relatively benign patients compared to those that are toxic. No? So here, the British Thyroid Foundation, and I'll cover this, suggests a very unique approach that has, for the longest time, not been used by endocrinologists, and this is the block and replace regimen for the management of thyrotoxicosis. And explain to you later why this is important as well. So the next point is it safe to defer definitive treatment for thyrotoxicosis? Defer radioiodine treatment. I think this was discussed by Dr. Lauderes earlier. Based on the prioritization, radioiodine treatment may not be necessarily be done at the moment because we are trying to prioritize the COVID patients. And as I said, the direction of the treatment or management is directed to those that are hit with this virus. So if you can defer it, ideally it should be deferred. But in most cases, we don't really have a choice because the radioiodine isotope is not available. And at the same time, the facility may be closed. Okay? So here is where the surgeons come in. So uncontrolled thyrotoxicosis, they may even require urgent surgery. But of course, the usual precautions, the screening of these patients, as well as the follow-up of these patients with the endocrinologist is very important. However, there is no clear-cut indication on when we will recommend urgent surgery. As I said, this is all new to everyone, and these recommendations are just shared for us to take in and consider if we are faced with this dilemma among the patients. So for post-RI patients, there's a low threshold for starting thyroxine therapy. The reason for this is that post-RI, in about a month time, these patients will already manifest with hypothyroidism. And best to start them already with levothyroxine if you're still in touch with them. Okay. So what about patients that had radioiodine therapy or surgery? Are they at risk for coronavirus infection? The short answer is no. No evidence for that matter. We don't have any evidence. No studies have been reported that show that these patients are at risk for coronavirus infections. Are there any considerations regarding supply of medications? Of course, yes. We do not recommend that you stockpile on medications because a lot of the other patients may not be able to secure their medications, and therefore hoarding is not something that we want you to do. So just get enough for you for 1 to 2 months. Hopefully everything will start to open up already and you'll be able to procure your medications. No? So we want to be able to provide, or at least give chance for everybody else to get their supply of medication. So earlier I talked about the strategy of block and replace regimen. So block and replace regimen pretty much does this, no? So you block the hormone production from the thyroid gland by giving the anti-thyroid medication. And then, since you've already controlled it, you are the one that's going to replace the thyroid hormone by giving levothyroxine and keeping this patient euthyrox. The reason why this strategy has been raised again is that it appears that this strategy can prolong the period of follow-up for these patients. No? So how do you do this? Patient presenting with clinical thyrotoxicosis with suppressed TSH. You have an FT4 that's elevated. And here you see 3 columns. You have the mild, moderate, and severe, depending on the level of FT4. For mild cases, you can start with 20 milligrams of carbimazole or methimazole once a day. For moderate, you can start with carbimazole 40 milligrams or methimazole 20 milligrams, 2 tabs once a day. And then for the mild cases, you give this for 6 weeks, moderate for 6 weeks as well. For severe or very high FT4, you give this for 8 weeks. After this period, of course, you add on the replacement. So the replacement is now levothyroxine, which is available at 25, 50, 100, 150. No? And in some cases, you have to cut the 150 to half to get 75. For those with a very low body weight, less than 55 kilos. For those above 55 kilos, 100 micrograms. After 6 months, you reevaluate the patients. So this is unique because this treatment strategy actually prolongs the follow-up, and you're pretty much in control because you're blocking the hyperproduction of thyroid hormone. At the same time, you're controlling the replacement as well, so you can titrate it. However, we don't usually do this in our setting, and if ever you need to do this, I think you will need the help of at least an endocrinologist to cover the adjustments that you need to make as far as this strategy is concerned. Okay, so what about the American Thyroid Association? So the American Thyroid Association focuses on the need for immediate medical attention if symptoms are actually manifested and these symptoms are urgent and life-threatening. So again, they emphasize that there is a rare side effect of anti-thyroid medications, 0.2 to 0.5, okay? And these rare side effects may manifest in some of our patients that are hyperthyroid, given anti-thyroid medications. They also stress that there may be an overlap in the manifestations of these patients, particularly in patients that are given methimazole, okay? And the best thing to do is contact or get in touch with your endocrinologist to determine whether or not you're actually dealing with a side effect or dealing with COVID itself. So the AACE position statement points out a lot of important things about thyroid disease, but I'm just going to focus on Graves' disease and hyperthyroidism. The most important key point here is that it is crucial for our patients to continue taking their medications as prescribed. And as soon as the healthcare providers are available, then you need to follow up for those adjustments or as needed, or if you need to proceed with definitive therapy for hyperthyroidism. Again, the issue on Overlap of manifestation of side effects of antithyroid as well as COVID is also raised, and you need to keep this in mind. And if you experience the symptoms, that may warrant a immediate consult with a healthcare provider. So the Philippine Thyroid Association also released an advisory to patients taking medications for thyroid disorders during COVID-19. Here, we emphasize that for those that are on maintenance levothyroxine for hypothyroidism, this should be continued. And for those that are on antithyroid medications, this should also be continued until such time that the ECQ is lifted and they're able to see their doctors as well. No? So in cases of emergency, this may warrant a visit, an emergency room visit, if really necessary for immediate assessment. Okay. Otherwise, we do believe that for a lot of the patients that are stable and taking their medications, they just have to take their medications continuously until such time that we are free already to move around and seek consult. So this is the latest that we have. This just came out, I think, a few hours ago. This is from the Journal of Clinical Endocrinology and Metabolism. This is a case report of an 18-year-old female presented with sudden fever, fatigue, palpitations, and anterior neck pain radiating to the jaw. This patient was COVID-19 positive. In the initial test, this is the column on February 21. You'll notice that the FT4, FT, and TSH are all normal. Even the thyroglobulin antibody and anti-TPO were also normal. This patient was assessed to be COVID-19 positive. And then at the time, they repeated the test and they noticed that the FT4, FT3 were elevated, TSH went down, the thyroglobulin antibody actually increased, all pointing into a subacute thyroiditis. No? So at this point, they started steroids that's very high, 25 milligrams per day. This steroid was gradually tapered in the next 2 weeks. And on follow-up, this patient already recovered from COVID-19. The follow-up test also showed that the thyroid function test reverted back to normal, including those inflammatory markers that ESR and CRP that elevated at the time that this patient had fully manifested COVID. This also normalized after a couple of weeks treatment with prednisone. So this is the first reported case of subacute thyroiditis that had previously was diagnosed with COVID-19. As we know by history, a lot of subacute thyroiditis was closely related to viral infections, but this is the first time that this was because of a COVID infection. Okay, so some of the key points that I'm going to end with. COVID-19 is a pandemic that's unprecedented in phenomenon. Its extraordinary measures are required to keep everybody safe. The presentations may mimic a rare side effect of antithyroid drugs, and immediate medical evaluation may be warranted. Thyroid disease is not known to be associated with increased risk of viral infections in general. Thyroid medications does not suppress the immune system. We ask our patients to continue their antithyroid medications since delays on follow-up are expected. Dose adjustment may be needed based on clinical parameters if laboratories are not feasible, but best to consult your doctor for further management if you suspect that you are not doing well. Telemedicine may be an option that you can consider. So life after COVID. So what will change? What can change? What should change? So these are some of the insights of one of the sites that I came across, and this is the Medical Futurist. Apparently, what will change is that it will have a toll on the healthcare workers, diminished trust in the globalized world, and the focus will be on the healthcare system. What can change? You have to change. We probably have to change our passport to the immunity passport, and then surveillance will be ongoing for public health measures, and of course, the habits will change. What should change? AI is necessary. A lot of us are afraid of it, but it's something that we need to consider if it's going to help us. A point of care is also going to change. The way we manage our patients, the way we approach our patients is also going to change. We need to find sustainable solutions. Overall, life will be significantly different after COVID-19. Thank you once again for listening, and thank you for inviting me to speak for today's symposium.
Okay.
Okay.
Okay. Thank you very much, Dr. Jeremy, and thank you to all our speakers. Now, looking at the feedback, I think all of the lectures are excellent and well appreciated.
Yeah.
Sad, but we don't have enough time for question and answer. We have been answering them in the Q&A box. So I would just like to call on Dr. Nemensio Nicodemus for his message, and then Dr. Torre for the closing remarks.
On behalf of the officers and board of directors of the Philippine Thyroid Association, we are indeed honored to be part of this joint symposium with the PCS, the PAHNSI, the PSGS, the PSOHNS, and the PSUS. We hope that this particular collaboration will continue, and we do hope that this particular joint symposium was able to enlighten everyone with the different aspects of the management of thyroid disorders that we need to consider, especially during and just to invite everyone, because this activity is a very good prelude to the celebration next week. May 25 to 30 has been designated as the International Thyroid Awareness Week, and the Philippine Thyroid Association, in collaboration with other subspecialty societies, namely the Philippine Society of Reproductive Medicine, the Philippine Society of Maternal Fetal Medicine, and the Philippine Society of Newborn Medicine, will conduct 3 joint webinars. On May 25, it will be the role of thyroid function on female reproductive health. On May 27, the role of maternal thyroid status on pregnancy outcomes. And on May 29, short and long-term effects of thyroid dysfunction on the newborn. The reason why these are our topics is because the theme for this year's International Thyroid Awareness Week is thyroid issues, mother and baby. And again, of course, all these webinars will be in collaboration with the Telemedicine Network of the Philippines. And so once again, with all the officers and board of directors of the Philippine Thyroid Association, thank you very much for making us part of this joint symposium.
Okay. Thank you again, Dr. Nemi. And to give the closing remarks, let us welcome the President of the Philippine Society of General Surgeons, Dr. Andrea Torre.
Good afternoon, everybody. We are glad that we are able to come together in this multidisciplinary conference. Although we may be online, this is our new normal. So I would like to congratulate PCS-PAHNSI, the Philippine Thyroid Association, and all of the other associations, PSGS, PSUS, and also thank you very much to Telemedicine Network of the Philippines for helping us with all of our webinars. Thank you, Jeffrey. I know that now is the time for your organization to shine. I would also like to announce, I am smiling because today we are celebrating the 21st founding anniversary of the Philippine Society of General Surgeons. Later on at 1 o'clock, the chapters will be showing their talents. I know that the chapters have prepared something for the fellows. Please go and check the websites. So again, may this webinar help us to continue to serve our colleagues in the community in these difficult and trying times. Thank you, everybody. Thank you for the learning. And thank you to all of the fellows and participants for sparing your time to learn more about what we can do to help our patients. Thank you.
Thank you very much. May request all speakers to stay for a picture taking. Dr. Salud, we need your picture. Wala na yan,
Okay,
sir.
sorry. Thank you, Dr. Jeff Domino, for Telemedicine Network.
Picture taking tayo, Ida.
Panelists.
Yeah.
Okay.
Yep, okay naman. 1, 2. Okay, that's it.
Okay, again, thank you to
Thank you.
PCS, PSE, and Telemed.
Very good speakers. Galing.
Okay.
Galing ng lecture.
Thank you, Doc Demi,
Thank you.
Doc Jeff.
Thank you, everybody. Great to see you. Take care.
We will
Jeremy,
share.
sorry again.
Ay,
We will
okay.
share. We will share the link to everyone so that everyone will have a recorded link as well.
Dr. Wesley, kahit
Ian,
busy.
thank you.
Doc AP, thank you sa
Thank
pagbigyan.
Thank you po.
And
AP.
Ian.
Everybody.
Ayos si AP. Dr. Nemi, thanks. Dr. Bobby, thank you very much.
Yes,
Bye,
yes.
Wes.
See you later.
Jeremy, hinay-hinay.
Bye-bye. Thank you.
Ingat sa Cebu.
Ingat.
Sige,
Ma'am,
Doc.
thank you.
Leave na. Pwede na, Jeff? Pwede na
Pwede na.
mag-leave?
Yep, pwede na.